Shall I go ahead now?
Yes.
Okay. So, good morning all. Myself, Lalan from Intas Oncology Marketing Team. I welcome you all for today's webinar on Hodgkin Lymphoma. Today's program director, Professor Dr. M.B. Agarwal said, though he doesn't require any introduction, but still it is my honor and duty to introduce Professor Dr. M.B. Agarwal sir. Sir is an institution in himself. He is inspiration for many and teacher of teachers. India is fortunate to have him, who has collaborated with many hematologists from across the globe and brought them forward in every weekend. Professor Dr. M.B. Agarwal sir is awarded with Inspiring Hematologist of India by Economics Times. And I also would like to introduce today's moderator, Dr. Amit Khurana sir. Dr. Amit Khurana is highly skilled and experienced in hemato-oncologist field. And sir has got almost 10 years experience in the field. Sir has a fellowship in BMT, hematology, clinical hematology, and sir is an expert in managing hematological and hemato-oncological disease. Sir is an expert in bone marrow biopsy, and sir has also got extensive experience in both autologous and allogenic stem cell transplantation. Now I request Dr. Amit to take over. Sir, over to you.
Thank you, Mr. Lalan. Let me set the screen over here. Can you please stop sharing the screen?
Yes, I'll stop here.
Thank you. So, well, very good morning to all of you, and good afternoon and good evening to all others who are joining from the rest of the world. Today, our guest speaker for the day is Dr. Kripa Bajaj from Hyderabad. She's going to lecture us on an update on Hodgkin's lymphoma. This webinar is brought to you by Mumbai Hematology Group, supported by Intas and managed by Perfect Square. I thank Dr. Manoj Kumar and the team Intas, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. K. Gayatri from Hyderabad, our guest speaker for the day, Dr. Kripa Bajaj from Hyderabad, and all our discussants who are themselves eminent hematologists and hemato-oncologists, as well as you participants for sparing your Sunday morning, afternoon, and evening. Next Saturday, that is on 24th of June from 7 p.m. onwards, we have a webinar on CMML and other monocytic malignancies, challenges in diagnosis by our own speaker, Dr. Jyoti Bajaj Soni from Gujarat Cancer and Research Institute, Ahmedabad. And the following day, that is on 25th June, Sunday, we have a webinar on mass spectrometry for multiple myeloma from 11:30 a.m. onwards by Dr. Hannah V. Giles from Birmingham, UK. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Abhishek Ranjan from Lalpur, Ranchi, Dr. Akanksha Garg from AIMS, Jodhpur, Dr. Akshay Manloy from TMH HBCH, Varanasi, Dr. Anushri Chaturvedi from Sundarpur, Varanasi, Dr. Avinash Pofli from Nagpur, Dr. Chirasri Sanyal from NRS Medical College, Kolkata, Dr. Gunjan Loni from Wockhardt Hospitals, Nagpur, Dr. Ketan Modak from National Cancer Institute, Nagpur, Dr. Krishna Ratnam Kannan from Sundaram Medical Foundation, Chennai, Dr. Kunal Chatani from Nagpur, Lieutenant Colonel Dr. Kundan Mishra from RNR Army Hospital, Delhi, Dr. Mona Vijayaran from Sahara Hospital, Lucknow, Dr. Mukul Agarwal from AIMS, New Delhi, Dr. Mulidharan from Wockhardt Hospitals, Mumbai, Dr. Rahul Arora from RST Hospital, Nagpur, Dr. Rajkumar Ramaswamy from Velamal Specialty Hospital, Madurai, Dr. Riya Balikar from Wockhardt Hospitals, Nagpur, Dr. Rizwan Akhtar from SGPJ, Lucknow, Dr. Swaswata Saha from Tata Memorial Center, Parel, Mumbai, Dr. Savitri Singh from Postgraduate Institute of Child Health, Noida, Dr. Shailendra Prasad Verma from King's George Medical University, Lucknow, Dr. Siddhartha Sankar Ray from Medical College, Kolkata, Dr. Stilin Chaudhary Bala from Nizam's Institute of Medical Sciences, Punjagutta, Hyderabad, Dr. Vishwadeep Kushu from AIIMS, Nagpur. Now it's a time to introduce our special guest for the day. Here with us, Dr. K. Gayatri from Hyderabad. Dr. K. Gayatri is consultant hematopathologist at Lifeline Tapadia Diagnostic Center, Hyderabad. She has been the consultant hematopathologist at Lifeline Tapadia Specialty Lab, Hyderabad since 2006. She was founder secretary of the Hematology Foundation of Hyderabad from 2005. This is not-for-profit organization for the care of patients with blood disorders. She was the founder secretary of Society of Hematology and Blood Transfusion of Andhra Pradesh. She was executive committee member of Indian Society of Hematology and Transfusion Medicine. She was the organizing secretary for Hematocon 2014. She is an associate editor of Indian Journal of Pathology and Microbiology. Formerly, she was additional professor of pathology at NIMS, Hyderabad from the year 1986 to 2002. She was also the chief of laboratory services at Global Hospitals, Hyderabad from 2002 to 2005. She has delivered various orations and keynote addresses, organized and conducted several professional workshops and conferences related to hematology and pathology. She is a recipient of Excellence in Teaching Award instituted by Cayley Society, Belgaum. She is also the recipient of Rotary Vocational Excellence Award year 2005. It's my privilege to welcome her to inaugurate our webinar and give some words of wisdom. Over to you, Dr. K. Gayatri.
Thank you, Dr. Amit, for your kind words of introduction. It is indeed a very great privilege to be among a galaxy. I literally mean a galaxy of hematologists, those actively engaged in the practice of hematology, whether it is in research, diagnostics, or in treatment. It is in my 4 decades of practicing hematopathology, I think this is a very proud moment to be able to see that so many young people have taken to this specialty. That in itself is a very, very satisfying experience for me personally. Having said that, all of us also have responsibility towards each other, towards our colleagues in other specialties, and most of all to the community that we all serve in. And I wish to just state a few things, nothing that you all do not know, nothing that you have not experienced or have goals about, but maybe a little emphasis from my own personal experience. We have seen an exponential growth in hematology and in entire medicine, and a lot of this is contributed via the field of hematology. A lot of basic understanding in medicine has come from search and questions asked in the field of hematology. And so we belong to a very, very elite group of medical scientists, I should say. So I think now the future lies probably, I think we will all agree that the future lies in a better understanding of an unraveling of more and more molecular basis of disease. And those that are pertaining to hematology obviously concern us. As we approach the and aspire for cure in hematologic disorders, these have mostly addressed the neoplastic hematologic disorders. And I think a lot of us find it very satisfying to be able to very precisely diagnose and offer precise treatment. But what we can do and we should take up is the work in non-neoplastic or benign hematology. This is where I think our future challenge lies. And in fact, in day-to-day practice, now, since for most diagnostic parameters and therapeutic parameters, for neoplastic disorders, they are well defined. What we really need to work on is how to strengthen our skill, our ability to diagnose, to understand, and to manage non-neoplastic disorders. And I believe that that is where our challenge lies. And I say this with to point out another aspect. When we focus on non-neoplastic or benign hematology, then we get to partner with specialists in other areas of medicine, whether it is pediatrics, gynecology, surgeons. A neurosurgeon may have a problem, a cardiothoracic surgeon may have a problem, an orthopedic surgeon may have a problem, a nephrologist, a neurologist, you name it, across all medical and surgical specialties. They will find our ability to support them through their crises and their problems very, very, very vital. And this is one area I think we can all focus on and find a fulfilling role for ourselves, even as we partner with our colleagues across all other specialties. I think that is a message that I would like to convey, even as we focus on a neoplastic disorder. Today, we're going to talk about Hodgkin lymphoma. And if you all can recall, there was a time when Hodgkin's lymphoma was called Hodgkin's disease. So our understanding has moved from a nomenclature difference to the way we manage, the way we diagnose, and the way we treat these patients. So if we could focus our attention on partnering with other specialists and others in our own field, that would be very rewarding. In addition, one last word, that we all also can perform a very responsible role in preventive medicine. There are so many inherited hematologic disorders that we can take charge of in terms of advocacy, as well as in helping arriving at diagnosis and counseling parents, counseling our society, people who are influencers in the society, to work towards preventing those disorders that we know that are preventable. And with these words, I would like to thank all of you for sparing a very important day today. I do not know how many of you remember your fathers today. You are all fathers. Everybody has a day to celebrate for their father. And today is Father's Day. Thanks for your time on this very special Sunday morning. And I wish Dr. Kripa Bajaj an excellent experience, even as she talks to so many experts across the country. Dr. Amit, thank you very much for this opportunity. I would be failing if I do not acknowledge the immense contribution that our mentors have performed in bringing us all together. Especially, I refer to Dr. M.B. Agarwal here, really an icon, to have the vision that it is possible to bring people across specialities, people across regions, people who would not have ever met each other. I may not have met any one of you if not for this platform. Thank you very much for Mumbai Hematology Group, Dr. Agarwal, Dr. Amit, for this excellent opportunity. Let's all enjoy the session. Thank you very much.
Thank you so much, ma'am, for the great words of wisdom, and a very, very happy Father's Day to you also.
Thank you.
Let me share the screen again. Now it's the time to introduce our guest speaker for the day, Dr. Kripa Bajaj from Hyderabad. Dr. Kripa Bajaj is consultant medical oncologist at Basavatanagam Indo-American Cancer Hospital and Research Institute, Hyderabad. She's going to lecture us today on an update on Hodgkin's lymphoma. Well, thank you so much. Over to you, Dr. Kripa Bajaj.
Is my screen visible?
Yes. Can you please put it in the full screen mode?
Yeah, I kept in full screen. Is it visible?
Absolutely perfect.
So first of all, I would like to thank Dr. M.B. Agarwal sir for giving me this opportunity. Not just now, from right from my student age, when I was training in Patanagar Hospital, he used to encourage us a lot to be part of this academic piece. And also, I thank Dr. Amit for my introduction and also introducing guest speaker as well. I thank Gayatri Madam for a wonderful message to all of us on Sunday morning. So today, my topic of discussion is regarding update on Hodgkin's lymphoma. So I would like, because it's a huge topic, I would like to discuss more of the advanced Hodgkin's lymphoma because all the update almost happened the advanced stage Hodgkin's lymphoma. So what's the theme of presentation today? So brief introduction regarding the Hodgkin disease, how we manage advanced stage disease right now, what are the new avenues in the management of Hodgkin disease, and how we are managing relapse and refractory disease right now with the new options available. So the scheme of presentation goes like this. So a brief introduction to all the students who are attending this lecture. So there are two main types of lymphoma. One is non-Hodgkin's lymphoma, other is a Hodgkin's lymphoma. Non-Hodgkin's lymphoma, lot of like variants are there, plethora of variants we do see. But Hodgkin's, predominantly two types. Not lymphocyte predominant, it's a different entity, the management will be different. And other is a classic Hodgkin's lymphoma. Today, our topic of discussion is regarding the classic Hodgkin's lymphoma. Again, classic Hodgkin's lymphoma constitutes four variants. Nodular sclerosing variant, which is the most common. Mixed cellularity variant. Again, the second most common, lymphocyte rich as well as lymphocyte depleted. So today, our topic of discussion is regarding classic Hodgkin's lymphoma. Coming to the history, Thomas Hodgkin was the person from whom we have taken the name Hodgkin's lymphoma. So it's a challenging pathology with a rare case entity. Hodgkin Rydberg stems, it constitutes only 1 to 2% of all the tumor cells. So this is the predominant entity to describe it's a Hodgkin disease. The IHC markers, CD30 positive, CD15 positive, PAX5 is V positive, CD20 negative. This is a classic Hodgkin's IHC picture. So as I told before, there are four classic subtypes of classic Hodgkin's lymphoma. Nodular sclerosing, equal age distribution, predominantly supradiaphragmatic disease, which is the most common type. Mixed cellularity, usually 50 to 30% will be constituted this variant. Usually it is Epstein-Barr virus related. Abdominal splenic involvement is predominant in this one. Lymphocyte rich, usually associated with the elderly, and it's a limited stage disease. Lymphocyte depleted, it is predominantly with elderly and HIV positive. Usually lymphocyte depleted variant will be advanced stage disease. So as I told, it's a usually the lymphomas arise as per the continuity of the evolution of the non-malignant cell to malignant cell. The B cell, on the way it loses the CD20 and gains CD30, it will transform into classic HRS cell. So the evolution of Hodgkin lymphoma treatment has evolved from basic radiation to combination of chemotherapy, later to PET adapted therapy. Till I was a student, lot of discussion and debates were happening regarding PET adapted therapy in Hodgkin disease. But right now, the frontline integration of targeted agents is the way to go forward regarding the management of Hodgkin disease. Let us go through the ride regarding the how we are treating and how we have to treat, we will treat the Hodgkin's lymphoma. So learning from the past, the MOP regimen or ABBD regimen, it's nearly 50 years old regimen. So there is not much difference from the past 50 years regarding the management of Hodgkin disease. We are really stuck in the time period, the timeline from past 50 years, no advancement had happened. Over the years, the long-term toxicities of high-dose radiation and intensive chemotherapy were recognized. So usually Hodgkin's lymphoma, Hodgkin disease, just now Dr. Gayatri mentioned, it is a bimodal aged disease. One of the most common cancers to affect adolescent and young adults as well as the older adults. So we see there is a two peaks are there in the incidence of Hodgkin's lymphoma. So if you see age 0 to 14 and age 15 to 19, the most common cancer to affect in teenagers is the lymphoma. You see the germ cell, leukemia, everything. But the IR group, 15 to 19 years, the lymphoma is the most predominant one. Out of that, Hodgkin's lymphoma is the one. So if you see the Hodgkin lymphoma, like across 10 to 30 years, like we see it's slowly increasing in time. It's occupying a good chunk of lymphoma incidence in these groups, like 10 to 40 years age. This Hodgkin lymphoma is the predominant lymphoma variant to be seen in this age group. The staging of Hodgkin lymphoma, I'm not going to index in detail, but its Ann Arbor classification will be there. And there are different lymph node areas. There are two groups, German group as well as other group. Lymph node areas are categorized as per each group. If you see, these are the lymph node areas. So supradiaphragmatic, infradiaphragmatic, and the number of lymph node areas involved, as per that the stage will be decided. Stage 1, stage 2, stage 3, stage 4. And how the management of Hodgkin lymphoma. It's 2023, but 2022, how it was. The cure is a predominant goal in Hodgkin disease, being the stage 4 as well. The cure constitutes a good amount of outcome. The cure with autotransplantation is next. Transplant ineligible or relapse post-transplant is a very negligible. So one of the most satisfying disease to manage for oncologists or hematologists is the Hodgkin's lymphoma. So as per the risk category, as per the early, favorable and unfavorable and advanced, different types of cycles as well as combined modality therapy will be there. Low risk, intermediate risk, high risk. High risk is mostly in the form of chemotherapy and target therapy plus or minus we offer. Low risk, intermediate risk, we can go for the chemotherapy absolutely, or we can do the combined modality therapy as well. In the advanced stage of Hodgkin lymphoma, the IPS is the International Prognostic Score for Advanced Stage Hodgkin lymphoma. It is the one which is the predominant prognostic factor. As per the score, the outcomes will be varied. If you see the Hasenclever index, like modified one, the outcomes are quite different. When you see the as per the score, the outcome is quite different. The factors constitutes are albumin, hemoglobin, male, age, stage of the disease, WBC, and lymphocyte count percentage, and absolute lymphocyte count as well. So, as per the IPS score increases, the outcome will be very poor. So early, I'm not going to discuss much, but I'm just briefing you. If in the very early favorable 2 cycles of chemotherapy is given, ISRT is essential. If you're giving 3 cycles in the early favorable group, if there is a bulky disease, the borderline bulky disease, RT is a reasonable option to offer because the outcome will be varied. If you're offering 4 cycles, then RT is not at all necessary. So full course of ABBD is required in the advanced disease. So usually female, male, I do have a consideration. Usually in female, I don't want to offer radiotherapy because there is exposure to the radiation for the breast as well as axilla will predispose to the breast malignancy. So usually calcium paradigm, I do adapt in the woman with more chemotherapy without any radiation. So what were the options available for advanced Hodgkin lymphoma? This is the topic of discussion for today. So what are the options available? ABBD 6 cycles, escalated BFOP 6 cycles, Brentuximab vedotin ABD 6 cycles, PET-therapy therapy, either escalation or de-escalation. What are the options we are offering to the patients? Little bit background. So ABBD is a good standard regimen from long time. Escalated BFOP and BFOP 14, these regimens are there from the long time. So usually escalation approach or de-escalation approach, what we are routinely following. And de-escalation from BFOP to ABBD and also avoiding radiation is most of the people are practicing when there is a high risk the disease is there. To start with escalated BFOP. De-escalation to few cycles of escalated BFOP or to ABBD in advanced disease as per the LISA study. So what proportion of patients is represented by high risk disease? IPS score more than 3, approximately 20% of advanced Hodgkin lymphoma patients will be there. PET2 positive disease after ABBD 2 cycles is approximately 20% disease patients will be there. Radiation therapy used less frequently, particularly when PET is negative. So what is the PET therapy, which was almost a debate and discussion? So 2 approaches are there for PET-adapted therapy in advanced stage disease. One is to start with ABBD and to escalate if PET is positive. This is what I practice. I prefer because of the toxicities keeping in mind. If patient is having a significant disease burden, young patient, we can also go for to start with escalated BFOP and de-escalating to PET2 negative. Means whenever I feel a patient may not attain PET negativity post ABBD because of the significant burden of disease, it's good to start with escalated BFOP. But significant burden of disease, but patient is like borderline or like likely attainable to have a PET negativity. Starting with ABBD is a decent approach. As for the clinician to clinician, the approach will vary. So what are the 2 studies which offer this? One is a RATTLE trial, which is a very important trial, which is the best approach, I would say, for the de-escalation. as per the long-term toxicities, everything keep in mind. Here, the advanced disease will start with ABVD 2 cycles. When PET negativity is there, this trial has de-escalated to the ABVD 4 versus ABD 4, keeping in mind bleomycin-related lung toxicities. When PET is positive, it was like BFF got continued, and further after 3 cycles or 4 cycles, as per the response, the call was taken. The primary endpoint is PFS for ABVD versus AVD. In this, if you see, when patient is PET negative post 2 cycles of ABVD, it's good to de-escalate to AVD regimen, and the outcome is equivalent. Absolutely curves, both curves are absolutely bang on with a good outcome. Rapid outcome in PET positive disease is like improved compared to the historical controls. It is not so significant decline. So it's good to start with ABVD and to escalate to BACOP because the outcome of escalation is not inferior. Other one, LISA, one very young person who's a significant burden of disease. This one we can offer actually as per the trial. The experimental arm offered escalated BACOP 2 cycles, and patient attained PET negativity after 2 cycles of BACOP. It was de-escalated to ABVD 4 cycles. Instead of escalation, this approach minimized the exposure to BACOP regimen. So when we are sure that patients having significant bulk of disease who will tolerate the chemotherapy, it's good to start with escalated BACOP regimen. When patient attained PET negativity, we can straight away de-escalate to ABVD. In this one, the positive patients were again continued on the BACOP regimen. So this negative ABVD versus standard arm were compared. If you see, so this is the one, this is the standard arm where like total BACOP got continued irrespective of the negative or positivity. Here, negative group ABVD was like de-escalation. If you see the outcome, the curves are again absolute bang on, there is no difference at all. So de-escalation approach is safe to play when patients are having a significant burden of disease, so that we can the exposure to chemotherapy, which will cause secondary malignancies and toxicities, will be minimal. So different background approaches, the outcomes are different. So we can't say which is the ideal answer to go like for all the patients. Still, there is an unmet need. Still, the outcomes are not so great. So PET2 positive patients have an inferior progression-free survival. In these patients, novel approaches are needed. Echelon study, I'll discuss later. So in Hodgkin's lymphoma, early cure, if you see, the cure is like very early, but as the time passes, irrespective of the follow-up, like decades and decades, there is a significant rise in the risk of second malignant condition, as well as significant rise in the cardiovascular events. So it's not just the cure. The patients who are getting cured, they're having the risk of second malignant condition, as well as risk of cardiovascular events. So balancing efficacy and toxicity is a way to go. PET scans allowing for more accurate staging and tailoring of treatment, as just I discussed before. Development of antibody-based target therapy has revolutionized the management of Hodgkin's lymphoma, because this part of the curve also we have to take care. The predominant survivors should not have any issues regarding the quality of life or further life. So what is the new in upfront therapy to tackle this problem? There are two molecules. So combine the standard chemotherapy, that is the ABD, with novel agents is the discussion for today. One is a brentuximab vedotin, other is a checkpoint inhibitor. So what is brentuximab vedotin? It's an antibody drug conjugate. It targets CD30, which is highly expressed in Hodgkin cells. It is taken to the cell. If you see the mechanism, like this will attach to the CD30 like receptor. It will be internalized, and the drug component will be released. That is MMAE, which is like a taxane component. MMAE binds to the tubules and disrupts the microtubule network in the cancer cell. So what is the side effect of brentuximab vedotin? It's a neuropathy, low blood count, fatigue, infection. So currently, what are the FDA approvals we are having for brentuximab vedotin? It's an untreated stage 3, stage 4 based on Echelon 1 trial in combination with ABD chemotherapy, and after autologous transplant or after 2 prior multi-agent chemotherapy regimens, we can offer as a single agent or as a maintenance therapy in high-risk patients after autologous transplantation. Second-line therapy by itself or in combination with chemotherapy, it's not an official label, but indicated guidelines and will be covered by insurance at all in the USA. So these are the FDA approvals currently we are having for the brentuximab vedotin. So Echelon 1 trial, which is most talked about trial, which is the buzz in 2022 NEJM paper, as well as all the conference beat ASCO and ESMO. What is this trial all about? So Echelon trial is an open label international randomized phase 3 trial Comparing Brentuximab plus ABD 6 cycles versus ABVD 6 cycles. End of the treatment PET scan is done. The follow-up is done every 3 months. So end of cycle to PET scan will be done as per that the management will be tailored. So the primary endpoint is a modified PFS. Key secondary endpoint is overall survival. So what is the outcome? So all advanced classic Hodgkin's lymphoma, they replace the bleomycin with the brentuximab vedotin. The outcomes, if you see, 3-year PFS and 6 years OS. If you see 3-year PFS, there is significant differences there. OS difference is also there. This is a drug which improved the OS for the first time in the Hodgkin's lymphoma. From the past 50 years, we are bound in one time loop where everyone is like introduced to the same ABVD and BA curve without no improvement in the survival. But this is the groundbreaking drug which improved the overall survival in patients who are having advanced Hodgkin disease. The 6 years update which recently presented in 2022, which got published in MEGM, if you see here, Brentuximab vedotin plus ABD had a 41% risk of death reduction compared to ABVD. So 93.9% versus 89.4%. The median OS not yet reached in the A plus ABD arm with a significant p-value. The OS benefit is consistent across all the subgroups, irrespective of the performance status, stage, age, and IPS categories. So the total analysis got adjusted as per the baseline demography and disease factors. So if you see the reduced risk of progression or death by, it is like 32% reduction is there. So again, it's very significant. And most importantly, what I discussed before is the risk of second malignancies. If you see here, there is a significant difference in the risk of hematological malignancies in patients ABVD versus A plus ABD, that is brentuximab vedotin. So this not only includes the overall survival, but also the second malignancy incidence also less. And toxicity is also less. Whatever the toxicity we have seen like during that is a neuropathy as well as GCSF requirement. So GCSF requirement and ongoing neuropathy is observed in the patients who receive brentuximab vedotin plus ABD. So apart from that, not much difference is there. Only neuropathy is the one significant component here if you observe. So the conclusion of the study is brentuximab plus ABD is the first regimen to show an improvement in overall survival versus classic ABD in patients with previously treated untreated advanced classic Hodgkin's lymphoma. Brentuximab combination improved OS despite the wide availability and use of active salvage therapies. There are few secondary malignancies. There is a reduction in disease progression. So hence, it is put forward to be preferred in the first-line treatment, especially patients who are unfit for bleomycin as well as elderly people. Remember, there is a inclusion of elderly people as well in this trial. So, is brentuximab vedotin plus ABD is going to enough for advanced Hodgkin lymphoma? If you see, the PET negative people, 15% people still have progressed. PET positivity, again, the outcome, as like discussed before, the PET positivity patient's outcome is not so significantly good. It is 61% outcome is seen. So what is the other novel therapy we are having in the armamentarium is the immunotherapy. Treatment that helps stimulate one's own immune system to fight cancer is the immunotherapy. So these are the rare malignant cells. That's a Reed-Steinberg cells who are surrounded by the immune cells. But the ineffective immune cells surround the Reed-Steinberg cells and are unable to eliminate them completely. So how immunotherapy is going to activate? This is without antibody. The cancer cell and immune cell is like not unable to fight against it. But with antibody, nivolumab, the immune cell is able to fight against the cancer cell. So what are the FDA approvals currently we are having for immunotherapy? It is for pembrolizumab, relapsed refractory classic Hodgkin lymphoma, and nivolumab, classic Hodgkin lymphoma that has relapsed or progressed after autologous transplantation, and brentuximab vedotin are 3-line systemic therapy, including autologous transplantation. So the outcome as a single agent itself, the overall response rates are CRs for both nivolumab and pembrolizumab is very good. But which patients to choose? Is it really important to introduce in the first line itself, in the upfront setting itself? Yes. So 9p24.1 amplification is enriched in advanced stage disease. The 9p24.1 amplified disease patients will have a significantly poor outcome. So if you see what are the predictors of response to nivolumab, it is the increased PD-1 expression as well as 9p24.1 amplification. There is a good improvement in the progression-free survival got noted. So checkmate 201 to 205. So nivolumab is like more available than brentuximab. So this was a drug which was offered to the people who are not eligible to take bleomycin or not fit to take bleomycin. So if you see this trial, nivolumab was offered as a monotherapy or 4 doses. It was combined with AVD and disease. Checkmate 205 is an advanced Hodgkin lymphoma trial. Nival trial is an early unfavorable disease trial. In this one, there are good response rates, nearly 84%, and complete response rate of 67% got seen, with a significantly less toxicities with good tolerability. So this was a buzz in 2019 to offer for the elderly people. So what about relapsed and refractory diseases? So relapsed and refractory diseases, as we all know, we do offer the salvage therapy. As for the PET adaptive therapy, we'll go for the transplantation. That is a routine one. Some different types of regimens are there. Some people will try ICE regimen. Some people will try DHAP, HAP, like multiple regimens are there. As per the physician's experience, we can offer. So prior participation in the clinical trial is suggested to the patient. If not, the classic salvage therapies can be given. So what are the transplantation approaches to be given? So usually transplant types, high-dose chemotherapy, autologous transplantation is the one to go. Allogenic stem cell transplantation only in select circumstances. Post-transplantation, maintenance of brentuximab or nivolumab. Brentuximab data as per the EPIRA is very strong. The outcomes are significantly better. So high-dose chemotherapy plus autologous transplantation is just a rescue. It's not the cure for some patients. Allow for higher dose of chemotherapy that might be possible. Stem cells collected prior. Beam is the most common conditioning regimen. So salvage therapy followed by transplantation. For transplantation, beam is the conditioning regimen to be used. If you're not rescuing the stem cells early, there'll be a bone marrow failure also. So beam transplantation, the outcome is only 15%, 55%. There are improved cure rates in the second line setting, irrespective of the relapse. So what can be done to improve the outcome in second line setting? To introduce brentuximab and nivolumab early. The outcomes are as good as 80% in these people. So to introduce during the salvage regimen itself, or to introduce a maintenance, we can use these two novel agents in the second line setting, in the salvage setting as well. So if you see, BB nivolumab alone, there is a 67% people attain PET negative. Whoever having a poor PS, we can offer this regimen. So we can sequence chemotherapy and brentuximab, or we can combine it and we can give along with that. The outcomes got improved significantly. You see 80%, 83% of the numbers we are seeing with introduction of brentuximab. So the sequential therapy combination PD-1 blockade I mentioned before. So this is the way to go for the salvage chemotherapy setting. I'm not talking about conditioning regimen, but salvage chemotherapy. Better to introduce this in the salvage setting early than a post-transplantation setting, because the outcomes are very good here. So what are the phase 2 studies which are available as a data for pembrolizumab? So these two studies are there, and pembrolizumab got combined with a GVD. So CR after 2 cycles, post 4 cycles, auto transplantation was done. So this is one study this is a phase 2 study though, but the outcome is substantial with overall response rate of 100% with CRs of 95%. Only 1% has had relapsed. And JCO 2020 publication, 2 years, there is like very few patients got relapse disease or didn't progress. At the same time, pembro also got combined with the ICE regimen, the second line therapy. The outcome is substantial. So prior we discussed regarding brentuximab introduction early, there are good CRs are there. And brentuximab plus nivolumab, there are good CRs are there comparable. And chemo plus immunotherapy also, there is a good outcome is there. If you see here, pembrolizumab plus ICE regimen, there are good PET2 responses. 86.5% complete response. Remember, this is in the salvage setting. So we don't know really like the chemo versus this. There's no randomization as such, but the randomization will answer the proper question, proper outcome regarding introduction of PD-1 blockade early. So success rate will vary. The baseline risk factors, depth of response, early response, prior use of brentuximab, prior use of immunotherapy, all these baseline risk factors will vary. The outcome will vary as per the baseline risk factors. So there is no randomized study to determine superiority of any regimen. It's mostly it's a physician choice and physician experience. So BV plus bendamustine, BV plus nivolumab, BV plus ICE, like 70 to 80% cure rate as seen. If you introduce the immunotherapy in the second line setting, 90 to 100% cure rate is like what expected as per the study what we are seeing. only chemotherapy alone, it's only 50 to 60%, only half of chances there. But introduce these novel agents in second line setting also, the outcome is going to be very different. So post-transplantation setting, immunotherapy, we all know this as a single agent, pembrolizumab has shown it is an effective drug. Compared to brentuximab vedotin also, immunotherapy has shown a very good outcome, 13.2 versus 8.3 months. So brentuximab vedotin alone, it also has shown a very good outcome with the 9% of people having sustained CR without any additional therapy post three lines of treatment. Other novel agents we are discussing is a fevazumab plus pembrolizumab, who are refractory to the PD-1 inhibitors alone. If we add LAG-3 inhibitor, fevazumab, so the outcome is going to be better. The response rates are good. So another one which was most discussed once in EHA 2022 and 2020 is chemidalanobor tesirine. So in this one, the response rates are substantial, but the response rates did not maintain. And also one more thing is there is a Guillain-Barré syndrome. 7% people develop Guillain-Barré syndrome, which is significant. So that's why this drug is not so popular. Chemidalanobor tesirine. So this drug response rates are good, but it didn't sustain, as well as Guillain-Barré syndrome incidence is high. So abscopal radiation, combining immunotherapy and radiation to sting tumor as elsewhere. In lung cancer, already we evidence that, but only like it's still going, the total results are yet to be out, and it's a very small group of patients receive this one. So the discussion will not complete without mentioning the CAR T-cell therapy in this era. So, but it's not CD19. CD19 is not the target in Hodgkin's lymphoma. It is CD30, which is target in Hodgkin's lymphoma. Apart from the apart from CD30, other targets are there, that LMP1, EBMA, LMP2 in EBV positive cells. So there is only phase 1 data is there. We can't replicate the same success in this one. We have to see the total data, limited follow-up, durability of safety. There is a small mention in JCO 2020, only 41 patients data is there with a good CRs of 59% and overall response at 72%. The 1-year PFS is 36%. Though the numbers are not as staggering as the DLBCL, but this is looking promising. We have to see the more data. So other approaches, novel approaches are combination of brentuximab vedotin plus nivolumab versus ipilimumab plus nivolumab plus brentuximab vedotin in the relapse refractory setting. So will this two combination is going to give a good CRs compared to the brentuximab vedotin plus nivolumab alone. So other what are the options available in cellular signaling blockade, cell surface markers blockade, checkpoint inhibition, nuclear export inhibition, epigenetic modification. These are the new avenues to be explored, and data is very limited. The topic for today's discussion, a very important update from ASCO 2022. So till now, what I discussed was the ongoing trials and everything. But as per that, like whatever I said is the brentuximab vedotin plus AVD Nextron 1 data I told, and checkmate 205 I told. But really, we don't know, like these two, till there is no comparison, and we don't know which one to offer to the patients. So we can't, we can offer only one, which is superior. If you see the second line setting, immunotherapy has scored really well when compared to the brentuximab vedotin. So is it really good to offer immunotherapy, or really good to offer brentuximab vedotin in the upfront setting? If you see here, checkmate 205 nivolumab, followed by nivolumab like ABD, and in echelon trial, brentuximab vedotin was continued. There is no good trial to say which is superior, which one to offer. And second line, there is a good outcome. At least cross trial is also looking very promising. And pembro versus brentuximab vedotin, the outcome data, like clearly pembrolizumab is a winner in the second line setting. But in the first line setting, if I want to introduce with a good outcome, good response, with the less toxicities, with the less second malignancies, what is the way to go? So as for 2023, there is a very good important update is there. There's a swap study S1826. It's a phase 3 randomized trial of nivolumab, Opdivo, or brentuximab vedotin plus AVD in patients with newly diagnosed advanced stage classic Hodgkin's lymphoma. This is the scheme of the trial. So stage 3, stage 4 Hodgkin's lymphoma patients got enrolled in that one, randomized to nivolumab plus AVD versus brentuximab vedotin plus AVD 6 cycles. So what is the outcome? So adult approach, pediatric approach, entirely different. Here, more than 12 years of age patients got enrolled in this one. So ABBD, BACOP, like these two can be offered. But in this one, what was the chemotherapy used was only ABD, but not BACOP. So if you see, so what is the baseline characteristics? If you see, the good amount of 25% people are IA group is there in both work. And 18 to 60 years is a good is a major population enrolled in this one. And more than 61 elderly, it is 9%, 9% and 10%. So stage 4, if you see, it is 62%, nearly 60% odd in this one. Stage 3 is like 40%. So bulky disease, good chunk again, 30%. So if you see, all risk factors are there. And B symptoms are present in nearly 60% of people. So all it's a very advanced stage disease got enrolled in this one. This is the toxicities outcome in both the groups. There is more neuropathy as expected in brentuximab plus ABD arm. And more neutropenia after nivolumab ABD, more growth factors used bone pain in brentuximab ABD arm. You see, the neutropenia is significant in nivolumab plus ABD arm. Otherwise, neuropathies, bone pains, and more growth factor use is required in brentuximab plus ABD. So there is no increased infectious toxicity. Usually immunotherapy, all will be alarmed that it's a hematological toxicity field. Super added nivolumab, there will be more infections. But that's not what happened. There is no increased risk of infections in nivolumab plus ABD arm. So treatment discontinuation and death. So if you see brentuximab patients, 22% treatment got discontinued, but in nivolumab only 11% got discontinued. So sticking to therapy, complex therapy is also more with nivolumab plus ABD arm. It's only just 1 year update. It's too early to shift to the treatment paradigm, but definitely this is a promising result. You see, nivolumab plus ABD improves the progression-free survival compared to brentuximab plus ABD. You see here, it is 94% versus 86% at 1 year. The follow-up is only 12 months, but there is substantial difference is there. The curve started separating very early, almost like nearly 6 months. From 6 months onwards, the curve started separated, and with a good hazard ratio of 0.48. So event-free survival again 91% versus 84%. The total EFS events are like 41 and 66 in brentuximab. So the event-free survival is also significantly better in nivolumab plus ABD arm. And if you see overall survival, it is too early to comment because it's only 12 months. We all know Hodgkin disease, advanced disease also, like the outcome will be at least 3 to 5 years, irrespective of the outcome. So 12 months, it is too early to comment regarding overall survival. But if you see the event-free survival as well as progression-free survival, the hazard ratios are significant. The numbers are really promising. Why we have to take this one? Because compared to brentuximab, nivolumab is like more available in the coming days with the generic introduction. Nivolumab will be more available. This is a therapy to be offered to the patients who are unfit, even not just for unfit, for all patients, because this will be the way to go. The outcomes will be very better and substantially improved outcome with less toxicities. So the PFS benefit is consistent across all the groups. If you see stage 4 disease, there is a the stage 4 disease group got a very good amount of benefit compared to the stage 3. So all groups got good benefit with the nivolumab plus ABD versus brentuximab plus ABD. So we proved brentuximab plus ABD is superior to ABBD in echelon-1 trial. In this walk study, we proved nivolumab plus ABD is superior to brentuximab plus ABD. So this is way to go forward. What is the upcoming trial? NIVAL study, I didn't mention regarding NIVAL study, but this is a study where brentuximab as well as PD-1. This is called a super regimen by Americans. So is it going to improve the outcome to introduce brentuximab and PD-1 early in the management? So here if you see PET negative people, PET positive, both are like randomized to ABD versus combination, SZ-BFF versus combination. Will the introduction of brentuximab and PD-1 early in the disease may improve the outcome? Whatever 5 to 10% outcome difference is there. So is it going to bridge that outcome difference? So this will update us regarding the early introduction of this novel agents in the management of Hodgkin disease and early also. NIVAL study already showed nivolumab is a very good drug to be introduced in the early stage unfavorable as well. So what are the combinations currently in trial in adult Hodgkin lymphoma? Checkpoint inhibitors at various levels. I told already the results are yet to come. Immunomodulators, Ibrutinib, ruxolitinib, everolimus also. So beyond second line, the combinations which there is some data available is for the pembrolizumab plus ruxolitinib, pembrolizumab plus ornostat, pembrolizumab plus entinostat. So the numbers are very small, 19, 32, 22. But if you see the response rates are 50%, CRs are 24% in pembrolizumab plus ruxolitinib. And pembrolizumab plus ornostat, the response rates are 75% with CRs of 34%. And among PD-1 refractory, the response rates are 61% and CRs are 11%. So PD-1 refractory triad ornostat, maybe that is going to improve the outcome. So again, pembro plus entinostat, again the response rate is 68%. What's important here, CRs are 45%. So addition of these drugs when we're using the single agent immunotherapy post transplantation, post brentuximab vedotin, maybe this is a way to go. Than single agent monotherapy, we have to add ruxolitinib or ornostat to have a better outcomes, improved outcomes. So what is the take-home message for today's discussion? Introduction of novel agents early in the management of advanced Hodgkin disease is the way forward. It has improved outcomes with reduction in toxicities. I thank Dr. M. Agarwal once again and for all the audience for patient hearing. I hand over to Dr. Amit Khurana for further proceeding. I'm more than happy to take any questions.
Thank you, ma'am, for that wonderful update on Hodgkin's lymphoma. What a sail through to all the agents and what an update. Thank you so much, ma'am. Now we have our colleagues over here who will discuss with you. I request all our discussions to please put the raise hand sign so that we can start our discussion. Well, first we have Dr. Kunal Shatani. Dr. Kunal Shatani, your question, please. You're muted. Please unmute yourself.
Good afternoon, all. Ma'am, what is your experience about accelerated BCOP use, its toxicity? Means how often you...
So
yes,
usually I do use this mediastinal, bulky mediastinal disease in young patients who are having stage 4. In my experience, offering ABVD is like the outcome is not so great. The PET positivity rate is as high as 50% in my experience. So that's why for young patients who are having a bulky mediastinal disease in stage 4, I try to give escalated BACOP. Okay. So if ever the same the de-escalation approach I do follow in these patients. Otherwise, rest of the patients I do offer ABVD, not escalated BACOP. Currently, I have 4 patients who receive escalated BACOP without any toxicities. They sail through with a wonderful CR rates, and I de-escalated them to ABVD for the next 4 cycles.
Thank you.
Thank you, Dr. Kunal. Dr. S.P. Verma, your question, please.
Very good talk, ma'am. Just wanted to know, like in AYA patients and young adolescents and young adults, what is your fertility preservation? What steps you take for fertility preservation? Is it routinely done for all patients or?
About 12 years for all, we are offering fertility preservation. So we are offering, we are saying that strictly telling the outcome, fertility outcome with escalated, which is much more worse compared to ABVD. So we are suggesting them strictly to do this semen cryopreservation who are about 12 years. Less than 12 years, we are saying what is the fertility outcome, but we are not suggesting them to do any preservation for them.
Thank you, ma'am. And what about bleomycin-induced lung toxicity? Like, how commonly you see in current practice, and how you manage that once this patient is detected with lung injury, bleomycin-induced lung injury?
So first of all, I would really like to see at the baseline itself that the patient is really fit to take a bleomycin. I strictly go through the PFT DLC. If patient I feel unfit to take bleomycin, I do offer AEVD because brentuximab vedotin is an expensive drug. Only one state of population can take brentuximab vedotin. So AEVD, that's etoposide. Tata Memorial Hospital recently published the data of AEVD. Like some centers also published the data in abroad. But AEVD outcomes are as good as ABVD outcomes. So if patient is not fit for ABVD, AEVD is the way to go. If a patient is on ABVD developing a dry cough, I'll be very skeptical to continue bleomycin. If they develop early toxicity with a mild dry cough itself, I'll withhold the bleomycin. Strictly in the baseline itself, I'll say any dry cough, even mild, you have to be careful about it. We will repeatedly ask any mild dry cough. If it's an early toxicity, like if you find it's early toxicity, signs of early toxicity, we try to do the HRCT. We'll see whether drug-induced lung injury is there or not. So we'll withhold the drug, we'll see the outcome. We'll definitely not reintroduce unless it's some RT, respiratory tract infection, we don't reintroduce bleomycin. So early toxicity, we try to curtail. Significant lung toxicity not happened to me, fortunately. But when I was in training, one germ cell tumor had a bleomycin toxin, which is significant. Patient was unable to get weaned off from the oxygen. He eventually died. But fortunately, till now, my patients only early toxicity, I curtail the treatment, and with AEVD alone, I manage.
Thank you, ma'am. Because that is the initial dry cough is very, very important to recognize. Once it is missed, the next dose of bleomycin is, life-threatening in these patients.
I agree with you.
Thank you, Dr. Verma. Dr. Akanksha Garg, your question, please.
Yeah, hi, Dr. Kripa. Very nice and crisp talk. I just wanted to know if have you given in any of your patients the newer immunotherapy agents as a frontline therapy, like brentuximab in combination with the AVD? And second question I'd like to ask you is that sometimes if you're giving ABVD as the first line therapy and the interim PET is showing dual score of 3, then what is your practice? Because, many of the times these dual 3 patients, usually they tend to have, poor response to further therapy. So I'd like to know your views.
Okay. So the second question which you asked, like ABVD 2 cycles, interim PET has shown dual score 3. So
Yeah.
if patient is fit enough, I would try to escalate to BA cough. But usually, like most of patients do fall in 30 to 40 years of age. So patient is like disease burden is high, dual score is 3. I try to escalate to BA cough. If it is not so, I try to continue ABVD only, because usually in PMS we used to have that practice. Even though PET-CT dual 3 used to continue with ABVD, the outcomes used to be good. And the notion was we can salvage if it is not respond, because 60 to 70% people will have a good response. And the infections are difficult to manage with escalated BA in that setting. But here I'm comfortably escalating to BA whenever the disease burden is high. The outcomes are very good. And the first question you asked, yes, I gave a nivolumab to patient who is elderly patient, 68 years smoker, known smoker. For that patient, I gave nivolumab plus ABD regimen, and he attained CR. Post 2 cycles itself, he attained CR. To start with, it's a stage 4 disease with bone marrow involvement, but fortunately, he attained CR with 2 cycles itself. I continued the same.
Okay.
Post nivolumab and the post 2 cycles ABD plus nivolumab I did, like he attained CR.
Okay, that's great. Thank you.
Yes.
Thank you, Dr. Akanksha. Dr. Rajkumar Ramaswamy, your question, please.
Good morning. The de-escalation in the field as well as the dose of RT in early Hodgkin's lymphoma.
Sorry, sir.
The de-escalation strategy in the role of RT in early Hodgkin's lymphoma.
Early
What
Hodgkin's
dose you want to
lymphoma,
give? What kind of field you prefer?
So early Hodgkin lymphoma depend upon favorable and unfavorable, sir. Again, usually females, I mentioned in the talk itself. So usually females, I try to avoid RT because of the risk of breast cancer. Usually the males, I try to de-escalate with RT, sir. If it is early favorable, 2 cycles plus 20 gray ISRT, we try to involve site radiation, not involve field radiation. If it is early unfavorable, we try to give 4 cycles plus 30 gray or 3 cycles plus 30 gray, depending upon the response.
Okay.
Thank you, Dr. Rajkumar. Dr. Anushri Chaturvedi, your question, please.
Hello. Thank you, Dr. Kripa, for a very nice talk. I have 2 questions. First question would be, like someone else asked, that if there is a PET positive dual score 3, but my question will be, if there is a PET positive dual score 4, still in which patient you will not give escalated BRCOP, but will consider them for radiation? Are there any cases like this? And the second question would be in pediatric Hodgkin lymphoma. Have you, which patients, which regime do you prefer? And are we using ABVD also? And if yes, which patients?
So the second question, what you used to, I mean, I'm not a pediatric hematologist, but when I was in training in pediatric posting, used to call the OEPA and COBDAC regimen. And ABVD is given about 12 years, we used to offer ABVD, but less than 12 years, OEPA like COBDAC regimen we used to offer. But I'm not a evident practitioner of pediatric hematology and pediatric oncology. I can't answer in total regarding pediatric because I have no experience in that. But adult oncology, yes, I would say. Dual scope 4 upfront radiation, I don't think so. We have to salvage it with some form of systemic therapy. Better way to go is escalated BRCOP. If not, we are unable to escalate to escalated BRCOP. At least we have introduced the other forms of therapy like nivolumab. Usually in TMH, we used to continue it actually sometimes. To see the post 2 cycles again, post 4 cycles again, we used to do the PET scan. But that's not the way. Definitely, we have to escalate to one form of therapy, either to BRCOP, if not fit, to add nivolumab to the chemotherapy background. Only radiation as a therapy forward, I don't think so that's the right way to go. Post escalation BRCOP also still patient is having in a palliative setting I would give, but not as a curative intent I would give, because with the armamentarium of so many drugs I discussed, radiation alone, and I don't think so it's an option to go forward.
I understand, not the radiation alone, just saying you will be continuing that you actually answered that 2 cycles will do an interim PET, but dual 4, but again we are giving 2 ABVD and then same. So that is my question, that which patient would you prefer to continue with ABVD rather than escalating to BRCOP? That is the question.
Okay, unfit patients I try to continue. I'll see the post 4 cycles PET. Fit patients definitely I'll escalate. Whenever I have a doubt, I mean, I'm sorry, did I get your question? Your question is which patients, in spite of having dual scope 4, you continue ABVD regimen? That's your question, right?
Yeah, this is the question.
So unfit patients alone, I try to continue and see, because the chance of like 30 to 40% response can be a possibility post completion of 4 cycles. But usually fit patients I never continue the same regimen.
The continuous question in this only, false positive PET. So what is your experience with that? The interim PET, and it is you clinically, I know it is false positive and you think. So what is your experience, how false to deal with this false positive PET patient?
So false positive, like concurrent infections you're saying, right? So usually the SUV and the SUV, whatever dual score we are using, will be definitely the description will be quite different if you see. The involved site, like new site, if you see the mixed response, whatever the primary baseline excellent response with a few new uptakes, then we'll understand the patient is having infection, but it's not a disease. So,
so this patient, this category of patient, also we'll be continuing for 2 more cycles. That will be, because that is very common and more with the pediatric age group we see, because the concurrent infection is
post nivolumab. I have seen that. Post nivolumab I have seen one case explained. So there was a mixed uptake was there. When I discussed before, when I discussed with the nuclear medicine people, they said this can be because of the inflammation, because of the immunotherapy. So that also one area where false positivity can be in pediatric, as you suggested, infections, and second is immunotherapy itself can cause more inflammation in to some point.
Thank you. Nice talking.
Thank you, Dr. Anushree. Dr. Krishna Ratnam, your question.
Thank you very much for your elaborate lecture at the Q&A. I go one step further in the interim PET. If you have an interim PET of dual 5, the dilemma is, would you go for a biopsy and salvage with the salvage regimen, or would you go to escalated BRCOP?
I will go with escalated BRCOP, sir. I'll go with escalated BRCOP, sir.
So you are comfortable with that, or not the salvage regimen, not biopsy and salvage?
No, I'll not do biopsy. I'll go for escalated BRCOP 2 cycles. I'll see the response. If it is not responding, then salvage regimen. But after salvage, I'll not.
Okay, the second question I have is post autologous relapse. Generally allo is indicated. But with the advent of checkpoint inhibitors, can we try checkpoint inhibitors and then follow up the patient?
Yes. So, yes, sir. There is a very good amount of data, even the pembrolizumab as well as nivolumab. The FDA approach initially was that post-transplant failures in refractory and relapse settings. So, with the advent of checkpoint inhibitors, post-transplantation, it's good to offer pembrolizumab or nivolumab.
Thank you.
Thank you, Dr. Krishnaratnam, sir. Dr. Muralidharan.
Hi, good morning to all. It's a wonderful talk. I just have two questions. The first question is regarding in the relapse setting of Hodgkin's lymphoma. You have shown few slides about pembrolizumab plus GVD and other PD-1 inhibitors. So do you routinely check the PD-1 status before giving the therapy in relapse setting? Is this going to matter, or we can directly give in those type of setting? The number two question is that we have similarly used one of our patient when I was in Tata. So with nivolumab with GVD, when a relapse setting, he was multiple relapse status. So we didn't have checked, but he was wonderfully responded. He's till now is good after transplant. So what's your experience in this type of salvage therapy?
So I would like to comment. I have shown one slide to you. Definitely PD-1 is a predictor of outcome, but PD-1 negativity doesn't mean that we should not offer PD-1 inhibitor, checkpoint inhibitor to the patient. So if the PD-1 is high, the patient will have a more CRs and more responses. But combined with the chemotherapy, PD-1 like a pembrolizumab we can offer irrespective of the PD-1 positivity. So the outcomes will be very good. I showed you both the ICE regimen combination as well as GVD combination. The responses are substantial with the CRs of almost 70%. So it's a way to go to club chemotherapy plus immunotherapy. The randomized trial outcome will answer the question how much benefit is adding to the patients.
Any personal experience in relapse setting in those type of patients with a similar salvage therapy in your setting?
So as of now, I didn't have post-DM, it's a 2 years of practice. I didn't have a relapse patient as of now, it's just two years of practice. So if ever I have, I will update you.
Okay. And any experience of allogenic transplant who have versus, as Dr. Krishnandam also asked the same question similarly. I just wanted to know when will you choose for an allogenic transplant in a multiple relapse setting after autologous relapse versus newer agents like PD-1? And if at all, if you are going to use PD-1 agonist or antagonist, sorry, how much time you are going to use till progression, or do you have a definite point?
So I want to answer two questions. First of all, with the advent of this checkpoint inhibitor data and everything, and once patient for post autotransplant allogenic transplantation to be like the outcomes will be needed. So it's better to offer immunotherapy plus immunotherapy plus combination or immunotherapy alone than going for allogeneic transplantation. And also post checkpoint inhibitor allogenic transplant GVH is very, very significant. I agree. All hematologists who are practicing BMT will agree with that. So post checkpoint inhibitor allogenic will be very, very difficult to handle. So with the current thing, offering checkpoint inhibitor is a way to go. If patient progressed on checkpoint inhibitor, the outcome is going to be very poor. If you do allogenic stem cell transplantation also, the patient will have a significant GVH. I think Dr. Amit Khurana should answer this question, who is a BMT physician than me.
True. The thing is basically, I would put allogenic stem cell transplant as a third line therapy. So when nothing is working, that is with the line of therapy for allogenic stem cell transplant in case of relapsed Hodgkin's lymphoma, number one. Number two, there was a beautiful update which Dr. Agrawal sir had given just a couple of weeks back regarding brentuximab-based therapy in case of relapsed Hodgkin's lymphoma. So the first line therapy would be, again, in a case of relapsed Hodgkin lymphoma, will be BV, or you can use a checkpoint inhibitor. But in our scenario, like in Indian setting, where nothing works basically, and patient is fit enough to go for allo stem cell transplant when nothing works, then that is a point where I will place this allo stem cell transplant in this era of immune checkpoint inhibitors and BV therapy. So first, again, it will be BV or a checkpoint inhibitor, and then would be a allogenic stem cell transplant to keep a gap between the two. It's just like a bridge to therapy. So you have a PD-1 blocker, you put a gap. That's why that gap will help you to fill up the patient, to prepare for the patient with allo stem cell transplant, because you have to select the donor, you have to search for the donor and everything, and let him settle down, let him come into remission, and then would be definitely we can go for allogeneic stem cell transplant. But again, there will be big risk of GVHD post stem cell transplant. But again, we have got no other thing options in our hand to go for allogeneic stem cell transplant, because relapsed Hodgkin's lymphoma as a third line therapy when nothing is working. And that is the point where we can go for an allo stem cell transplant, not as a second line, not as a third line, but I will put it as third or fourth line of therapy.
Thank you, Dr. Amit Khurana, for answering this question with your experience.
Yeah. So that's the thing. Dr. Rizwan Akhtar, your question, please. You're muted.
Dr.
Yeah.
Rizwan, you're muted. You're muted.
Please unmute yourself.
Thank you, ma'am, for a wonderful talk. I want to ask a question regarding relapsed Hodgkin's lymphoma, 12-year female. She has been treated with salvage chemotherapy of GDP for 3 cycles, after which her PET score is DS3. So what next should we go with the transplant, auto transplant, or any change of therapy is indicated? Your thoughts?
So I do, if it is dual score 3, I would like try to change or add some immunotherapy or immunotherapy to the patient. I already showed you the salvage setting. Additional brentuximab or addition of immunotherapy will have a better responses, deeper responses. So I would like to add checkmate inhibitor or brentuximab to this patient.
How many cycles, if we give brentuximab, then how many cycles?
Post to 3 cycles, I do the response again, I will see.
Again, post 3 cycles, we will check the response.
Yes.
Thank you.
Thank you, Dr. Rizwan. We have got some couple of questions from the audience. Dr. Hitha wants to know, for the treatment for NLPHL stage 2 disease, what will be your first line regimen therapy?
So currently my choice is ABVD. It's not not based on, I just offer ABVD regimen to the patient.
This is for the NLPHL stage 2 disease.
Yeah.
Another question from Dr. Shabin George. In first line setting,
so actually the classification what was used is a combination of Nivo plus this thing. I will try to continue. Immunotherapy is not just like chemotherapy where you attend it. So better you sustain the response with immunotherapy, continuous immunotherapy, irrespective of the thing, so that the response will be long lasting. Hodgkin's lymphoma is an immunogenic environment disease. So better I give more immunotherapy to them so that the response will be lasting. So just now I got PET2, I will not stop the immunotherapy. So I will just stop it and just continue chemotherapy.
thank you. I have got a question for you. Suppose your patient has relapsed after a patient has advanced stage Hodgkin's lymphoma. This is 2 cycles of ABVD, was in PET negative after 2 cycles. You are given AVD, de-escalated the patient to AVD 4 cycles, and after 4 cycles, the PET was negative. After 2 years, the PET becomes positive. Now, what would be your regimen of choice? I will give the option to you. Whether do you go for Pembro plus GVD, whether you will go for BV plus Nivo, or whether you will go for BV plus Benda, out of these 3.
So Pembro plus GVD is my regimen of choice. And actually GDP, I would say, because GDP we were most comfortable without Pembro for a long time. So Pembro plus GVD, there is a data is there, but yeah, Pembro plus GDP or Pembro plus GVD, either is fine for me.
And what is your talk on elderly Hodgkin's lymphoma?
Elderly Hodgkin's lymphoma, as for the recent one, I would like to give Nivo plus AVD, not Brentuximab plus AVD.
What about BV plus Decarbazine?
No, I will not offer BV plus Decarbazine.
And
the
about,
data is like good data, but this is more superior compared to that.
and your take on sequential therapy in elderly Hodgkin's lymphoma with the use of BV plus AVD, 2 cycles followed by AVD, followed by again BV. So are you using
So I'm not using that, sir. I haven't used that sequential therapy now that.
it? So I think we have finished all the questions from the audience. Oh, yes, one more question has come. Dr. Pujita wants to know, what's your experience on haplo-identical transplant in Hodgkin's lymphoma? If you're planning for haplo, what gap do you give after stopping immunotherapy?
I'm not a transplant physician, Dr. Amit Purana, could you?
Well, I will answer that question actually. First of all, haplo will not be my first choice for Hodgkin's lymphoma. It will be dangerous to do that. If I'm getting mud or if I'm getting med sibling, then it's fine enough. If not that, then it will be haplo. So again, there should be 2 months of gap between the immunotherapy and the haplo transplant, any transplant. So that is the answer for that. Another question is from Dr. Shyam. If the cost is not an issue, what will be your choice of therapy? Nivo plus BV or Nivo plus AVD or BV plus AVD?
My choice currently is Nivo plus AVD regimen, not Nivo plus BV regimen. So I saw already toxicities of BV and the Nivo. AVD plus Nivo is the way to go because cost is not just the issue. The outcome will be better. There is no randomized trial saying this is superior to that. Definitely chemotherapy backbone, I do use it. Chemotherapy totally, I'll not omit.
Thank you. I have another question for you. If you're going for a transplant in case of relapsed Hodgkin's lymphoma, regarding the Athera trial, which took place for a 5 years update on that, regarding the BV, about 16 doses of brentuximab post-transplant. Have you used any of them post-transplant, your experience?
So I saw people offering it because I'm not a transplant physician, but definitely it's a very good drug to offer for a post-transplant people who are having high risk of relapse. The outcomes are really good with brentuximab versus placebo.
Thank you. So anybody has any question for ma'am? So I finished all the questions from the chat box. And no question left over here. Yeah, one more question. Again, a question from Dr. Hita regarding that NLPHL question. Will you combine rituximab in the treatment of NLPHL?
So the outcomes are usually rituximab arch operation and we are offering in the stage 3, stage 4, but ABVD outcomes are equally good. There is no point of offering, like there is not so great benefit of adding rituximab for such patients. But stage 3, stage 4, we are offering arch op. But stage 1, stage 2, like we are going for a ABVD regimen only, unless it is like, unfavorable risk is there, our patient is having a bulky disease, where we are not adding rituximab to it.
Thank you, ma'am. So any other question? So I just want to add about this allo transplant in case of Hodgkin's lymphoma. So the patient is relapsed, Hodgkin's lymphoma. You're going for autologous stem cell transplant first. That will be a second line of therapy. Now, again, the patient is relapsed. That is the third line of therapy has to be added. So we are adding BV can be given. Again, it can be given. Or we can also go for this pembrolizumab or nivolumab-based therapy to put the patient into remission. So what experience I have is if you're taking the patient for allo stem cell transplant, it's a third line of therapy, a third or fourth line of therapy after the immune checkpoint inhibitors, because just immune checkpoint inhibitors are just going to help you as a bridge to transplant. And after that, about 2 to 3 months as a bridge to transplant, you can go for a stem cell transplant. But again, allo stem cell transplant will stand at third line or fourth line of therapy only. It cannot be the second line of therapy. So fine. So no other question. Anybody else has any question? So, well, if no other question, I think we'll come to the end of this discussion. Thank you so much, ma'am, for a wonderful lecture and what an update. And thank you so much for a wonderful question answer session. And I now hand over.
Thank you so much, Dr. Amit, for answering all the transplant questions, because you are a great help to me today because you're a moderator.
Thank you. I now hand over to Lalan, Mr. Lalan from Intas for the final vote of thanks.
Yeah. So thank you, sir. Thank you, Dr. Amit Khurana, sir. It was a wonderful discussion. And thank you, Kripa ma'am. And I would like to thank all panelists, Gayatri ma'am, for having spent time on Sunday. Thank you and see you soon.
Thanks
Thank you.
everyone for patient listening on Sunday. Thank you so much, ma'am and Amit sir.
Thank you. Thanks for joining. Thank you so much, Kripa ma'am. Thank you so much, our chief guest, Dr. Gayatri ma'am, for your wonderful words of wisdom. Thank you all the discussants for joining here. And definitely thank you all the audience to spare your Sunday morning today. Thank you so much. See you next week, Saturday, Sunday.